Just to relax your neurons after Dr. Sachs' talk. I'm an anesthesiologist. That's what I'm doing in daily practice. So this talk about pain management and spinal cord injury. Pain is defined by the ISIP. The definition was updated in 2020 as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is classified as acute if it is less than 12 weeks or chronic if it is more than 12 weeks and persists despite an apparent lack of ongoing injury. Chronic pain impacts about 70% of spinal cord injury patients, with 1/3 of these patients experiencing severely intense pain impacting mood, function, and quality of life. The pain can be nociceptive, neuropathic, or visceral. The nociceptive pain is the most common and can be due to initial trauma, muscle, or joint overuse, for example, upper limbs and wheelchair use, and injury related to muscle weakness, spasm, contractures. Neuropathic pain can develop acutely or after even 1 year post-injury and can present at or below the level of injury. Visceral pain is thought to originate from the abdomen or thorax and may be related mainly to constipation. The classification of pain in spinal cord injury patient, it's classified in three tiers as defined by the International Spinal Cord Injury Pain Group. In Tier 1, we find there are nociceptive pain, neuropathic pain, other pain, unknown pain. Tier 2, and nociceptive pain could be musculoskeletal pain, visceral pain, other nociceptive pain. And neuropathic pain could be at the level, below the level, other neuropathic pain. In Tier 3, we can see in nociceptive pain like shoulder osteoarthritis, constipation, autonomic dysreflexia, and neuropathic pain, spinal cord compression, spinal cord ischemia, carpal tunnel syndrome, pudendal neuralgia, and other pain could be fibromyalgia, irritable bowel syndrome. So the pathophysiology of chronic pain and spinal cord injury. After spinal cord injury, the structural neuroplasticity and sprouting of new dendritic fibers is critical for recovery, and it is the change that may add to neuropathic pain, muscle spasticity, and autonomic dysreflexia. At the level of injury, neuropathic pain is thought to result from hyperexcitable neurons which have exaggerated responses to stimuli or at below the normal activation threshold. Hyperexcitability results from altered expression at the NMDA and glutamate receptors, sodium and calcium channels, increased glial activation, or at hypofunction of endogenous inhibitory neurons. Below the level of injury, the mechanism of perceived pain are less clear. In complete spinal cord transection, the origins theoretically must be in the intact portion of the central nervous system above the level of injury. In these patients, the source of pain generator is unknown and could arise from the spontaneous activation and disinhibited polysynaptic pathway, a sensitized spinothalamic tract, or from more central regions such as thalamus or the cortex. An alternative explanation is that below the level pain could be produced by dysfunctional relationship between the fast lateral spinothalamic tract and the slow and medially located polysynaptic pathway. It is possible that post-injury, the polysynaptic tract may dominate over the spinothalamic tract, which explains the late onset and diffuse nature of pain with its associated after sensation after a stimulus. Crucially, polysynaptic pathway is also capable for transmitting and deafferent pathway, giving the sensation of pain below the level of injury. The International Spinal Cord Society published last year clinical practice guidelines for rehabilitation and management of neuropathic pain after SCI. They focused initially on a proper assessment, history, examinations, proper imaging, and they validate these tools, screening tools, and which is also validated by multiple languages, German, Brazilian, Chinese. So the first tool is spinal cord injury pain instrument, and the second neuropathic pain symptoms pain inventory. If we just screen the first tool, so we just ask a patient a yes or no question. Is the quality of pain electrical or electrical shock-like? Is the quality of pain like pins and needles or tingling? Does the skin over the area of pain or inside your body where the pain is located feel hot, burning, or cold, or freezing? Is the skin over the area of pain abnormally sensitive to touch and without any surgical scar, ulcers, breaks in the skin? Is the pain usually unchanged with movement of the painful area? Do you experience pain all the time without any breaks when you are awake? And these are the 7 questions for the spinal cord injury pain instrument. So they recommended in initial guidelines, there was first, second, and third line of therapy. So now they make it as a first line, then the others considers as an options. So B options, C options, D options. There is no consequences of the there is no sequence of these options. So the first line, the following medication should be used in the treatment of neuropathic pain after SCI, pregabalin and gabapentin. The first it's included in the first line, but put it in another sentence because of the side effects of the amitriptyline, especially in spinal cord injury patients. So in B options, the following can be used for neuropathic pain: oxcarbazepine, lamotrigine for incomplete spinal cord injury, and tramadol. In C options, transcranial direct current stimulation, combined transcranial direct current stimulation and visual illusions, botulinum toxin injections in the below level at the most local in the muscle that generates the neuropathic pain. So it's a local injection. The D options has TENS, oxycodone, and DRES. So Keppra and mixilotine also, they state that should not be used for reducing neuropathic pain intensity among a person with the spinal cord injury. So there was general treatment principles from an expert opinion focused on multidisciplinary teams and coping and managing strategy, pain educations, the role of CBTs, etc. These are modalities that requiring further research: transcranial magnetic stimulation, visual illusions, acupuncture, exercise, spinal cord stimulation, even with the multiple case reports and animal studies, massages, osteopathy, duloxetine, IV ketamine, lidocaine, alfentanil, clonidine, and morphine. So in a recent review last year by a team in the Mayo Clinic about they reviewed the literature on spinal cord stimulation for neuropathic pain after spinal cord injury, and also they found lacking of evidence of spinal cord stimulation. So in general, neuromodulation, invasive neuromodulation for spinal cord or brain should only be considered when there is severe debilitating chronic pain and all other therapies have failed. Evidence regarding the use of spinal cord stimulation are weak. Deep brain stimulation is more effective in nociceptive pain than the efferentation pain. Motor cortex stimulation has a better clinical potential, as it has a fewer complication than DBS and central pain and SCI patients. Thank you.